are some. Oh, okay, recording in progress. So there are some important things to look at. So first of all, she's the right age group. She's 70 years old, and what we need to know is with Parkinson's, over 1% of over 60s will have Parkinson's disease, and it's the second most common neurodegenerative condition. So she fits with that. We see, going down that she takes no regular medication. So we know drug-induced is unlikely to cause this. And then, as it mentions, we look at the resting tremor there, which is in the right frequency, okay, 3 to 5 hertz, although you will read in different textbooks they can be 4 to 6. And with this, then, they subtly mention that reduced arm swing on the right-hand side. And this is typical of Parkinson's disease, and this is suggestive of Braided Kinesia. And this is a very subtle way of checking for that, as well as obviously the problems turning once they've walked a certain path. So certainly doorways are a difficulty. Now, the tremor in Parkinson's is very unique. Yes, it's that typical pill rolling, and we always think that it's in the hands, but actually you can also have it in the feet and the legs. So don't be deterred if somebody comes in like that. And some patients, at least 20 to 30%, will not have any tremor, which is why it's not a first-rate symptom for diagnosis, the Braided Kinesia is. But a good hint is always, if you're trying to tease out the tremor, is to ask the patient to do another task. So recite the months of the year backwards is what I do. And typically, as they concentrate on that, the tremor will get worse. Now, if we compare this to the other answers there, essential tremor, well, that's normally symmetrical. So this is a postural tremor. There's normally a family history. And also some patients will say that temperature will affect the nature of their tremor. So actually worse in warmer temperatures. And this is a much higher frequency, it can be up to 12 hertz. So patients can find it really difficult with normal ADLs. And with this, you can get the tremor, particularly in the head and neck, which is rare in Parkinson's, but also the vocal cords. You can have essential tremor, the vocal cords leading to this rather dysphonic voice. Now, thyrotoxic tremor, I'm sure you all know, is a fine tremor. Always I like to put a piece of paper on top of thyrotoxic patient's hands, and you can see that fine tremor rather nicely. And then D is drug-induced. So if we look for those, as I said, there doesn't seem to be the case here, but typical ones that you would look for are kind of lithium, SSRIs, tacrolimus as well for immunosuppression, for transplant, for instance, antiepileptics like valproate. And don't forget, obviously, withdrawal from drugs, such as benzodiazepines and alcohol. A Holmes tremor you may not have heard of, but this is basically I suggest you look at this, because once you watch it on YouTube, you won't forget. It's what we call a wing beating tremor, because you'll have very rapid movements of the hand. And this is basically a mixture of a kind of rest, postural, and action tremor. It's usually much slower, kind of 2 hertz, but it's wide amplitude. And it really is a sign of cerebellar damage. Okay, so this is something that you can use to localize the lesion. So well done for those who got A. Let's move on to the next question. And we'll give 2 minutes of this one. Feel free to ask questions. 30 seconds left. I'm going to stop there because I think this one people will know. So can some people tell me? Yep, so I think we've got D as an answer. We've got B. Some more people, feel free just to write. We've got B with a hashtag. That's in fashion. Or B sharp if you're musical. B. Okay, so the right answer here is, oh, just click, is increased steps on turning. So as we said, the triad for Parkinson's is the fact that they should have tremor, rigidity, and increased tone, and they should have Braided Kinesia. So we've mentioned here that the Braided Kinesia is present, and because of this, they will have great difficulty with the rigidity and things to navigate very tight spaces, and turning is a particularly good way when you're assessing the gait of somebody with the suspected Parkinson's or Parkinsonian syndrome. Now, if we look at the other options, let's just think. So some people put D, for instance, another one. So increased arm swing. There are very few things that should cause an increased arm swing. However, there is one type of gait that we see. So this is what we call a marché à petit pas. Okay, so the French. I apologize if anyone's French and thinks my pronunciation is awful, but this is, it looks very similar to Parkinson's. They will do extremely small steps, but some of the unusual things is that they will have preserved and can have increased arm swing. And likewise, they don't kind of bend over, loom over, that what was used to be called a simian posture. They will actually stand upright, but they will seem to be almost jogging on the spot when they walk around. And that is a sign of usually very severe kind of small vessel disease or bilateral kind of cortical lesions, but also can be seen in normal pressure hydrocephalus. So what we call that kind of a praxic gait, where the feet are almost stuck to the ground, so they can't move. If we look at the broad-based, well, broad-based gait is what we're looking for with Cerebellar. Oh, yeah, somebody asked how to spell that. Yeah, I'll write that in as we're doing it. So there you go. But broad-based obviously leads to a whole host of differentials, and I would suggest you learn them according to, are they bilateral, unilateral, or not. So common ones, if this is a young person, you would think of it's cerebellar lesions. A young woman, MS would certainly be up there. If it's unilateral as well, you would think of tumors or strokes. If it's bilateral, you would think more genetic, and this is where you would want to think of unusual forms, but certainly things like Friedreich's ataxia, but also toxins, maybe that they're on phenytoin. Now, a waddling gait was mentioned, and a waddling gait is a sign of muscle weakness. So this is a myopathic gait, or you may have heard this under Trendelenburg's gait. And this is where when they have basically pelvic drop, so that when they lift up their leg, so with the leg that's lifted whilst they're walking, they will get basically droop on that side, and the side where the foot is on the floor is then they'll have a kind of a lateral kind of raise of that side. So they'll have a droop on the side with the lifted foot. And that is a waddling gait. So you would think it's of myopathies rather than anything else. But also you can conduct your kind of normal exam. Now, can anyone type into the chat about a scissoring gait and what they would think of with that? Nobody wants to, then that's fine. Carry on. Anyone want to hazard a guess about scissoring gait? Palsy, yeah. So well done. That's fantastic. Cerebral palsy is a prime example. So what we're looking for when we say scissoring gait, this is whatever it is. This is a bilateral upper motor neuron problem. So they have inward turning of the kind of ankles and legs, and they will, as it says, scissoring gait. So they will have problems with circumducting and the typical things that you think of as cerebral palsy. But as I said, you should be looking, because it's bilateral, for problems in the spine. So spinal cord trauma is a very good one. And you would also want to think of, myelopathies that are affecting the spine, but certainly cerebral palsy is there, and you would expect with the scissoring gait increased spasticity and appropriate kind of weakness there. But some and the cerebral palsy, obviously, some of the intellectual disability comes to that diagnosis. Well done. So let's move on to the third question. Obviously, feel free to ask questions on the chat to us, and we'll get through them. Oh, I didn't realize this was here. So yes, so we're talking about Parkinson's disease. So as we said, the key things are resting tremor, rigidity, braided kinesia, and postural instability. Now, what I'll say to you about this, as I said, is that the tremor is not diagnostic. It will be missing in about 20-30%. So it's the braided kinesia that's key. Ask them, is it harder for you to stand up from the seated position? Ask them to do piano sticks, so trying to quickly alternate their fingers pressing against their thumb. You'll often typically find that slows down after kind of 15 seconds. And then postural instability comes on a little later than you would expect with some of the other Parkinson plus syndromes that we'll talk about later. Now, in terms of differentials, we've talked about kind of vascular. So obviously you can get vascular Parkinsonism drugs, and we'll come on to that in Parkinson plus. And we'll talk about the nuances, how do you differentiate these. But one key thing with the tremor is differentiating between essential tremor. They can exist in the same patient. So there are Parkinson patients who will have coexistent essential tremor. The key thing with that, as I said, is that the essential tremor is worse, usually postural, holding the hand or the affected limb outwards. It's usually symmetrical. There's a family history improved when using alcohol, which is why people often report that. And if you ask them to write, well, a good thing is that with essential tremor, actually, that should be fine. And as we know with Parkinsonian symptoms, micrographia can be a very severe and very early symptom. Now, something I'm very interested in is the non-motor symptoms. So I'm very interested as an ID physician about changes in the gut microbiota, which predate motor symptoms in Parkinson's. There's a paper you can read about it if you're interested, but the key thing is to always ask patients about some of these other things. So anosmia is actually a very, very good symptom to ask for. In Parkinson's, they can occur up to kind of 3-4 years before they manifest, as will things like constipation. So constipation without cause and kind of slowing colonic studies. This is another symptom that you'll see, as well as REM sleep disorders. They're probably the biggest ones that we will see pre-motor symptoms of Parkinson's. Obviously, going forward, we know that we'll get autonomic problems, and that can manifest as orthostatic hypertension, problems in micturition, but also other issues in terms of bradycardia. So there's something to be aware of. And obviously, dementia is something very, very important. So when you're assessing somebody with Parkinson's, normally I've been there, you kind of say well done to yourself because you've noticed the tremor, and then you think you've had a go at the tone and you think, yeah, it's cognitive rigidity, so I'm done. The key things are now you need to tease out, is this the actual cause? Is it Parkinson's disease, or is this actual Parkinsonian symptoms? So that's why you should do the line standard blood pressure. As we'll discuss later, check for cerebellar signs. I would suggest that, not only because of some of the Parkinson plus, but particularly if you're wondering if there's, for instance, Wilson's or Huntington's other features which may fit into that. Check the drug chart, because I found that on a ward round once as an F1, Parkinsonism secondary to that, and they would be investigated for Parkinson's disease, and do a full neuro. So, with that in mind, let's move on to question 3. 2 minutes, unless people beg me to. Cool. Okay, so we've had about 1.5 minutes and somebody's already answered. Yeah, okay, so I can see a pattern here. Anybody else want to answer? So we can, I want to see if there's consensus, because I can't do a poll. Not that I'm saying that B is right. Okay, there's a lot of B's coming up. Right, okay. So the correct answer here is indeed B. So, as we said, kind of looking at this, he's clearly got signs of Parkinson's. We know that. The key thing is now is that it seems to be affecting his quality of life. Now that's when you start treatment in Parkinson's. You don't start it straight away. You wait, and often you can wait for actually even up to kind of a couple of years before they need to start L-DOPA. And levodopa still to this very day is the best treatment that you can offer, not the others that are listed. Now, interestingly, you might see the withdrawal of losartan, and you might snort with derision because what does that have to do with it? But interestingly, there are case reports of patients who have worsening of their Parkinson's disease on losartan therapy that actually when it's restarted, when it's withdrawn and then restarted, they actually get worsening features again. So there does seem to be some link, however, that it doesn't have any biological plausibility. Now, Miranda's asked, when do you start it? Yes, you start not when they start showing symptoms, because that's how you've diagnosed that they've got Parkinson's. It's when it's now starting to affect the quality of life, okay, and affect them. So with him, this chap is having issues actually getting around now in the house, and actually having issues with that. So this is where you would make a MDT decision to start somebody. Now, L-DOPA, as I said, you will give this with something to prevent its breakdown. So you'll have the common kind of combination cobenl-dopa, for instance, to give to try and prevent that. And a key thing that you need to be aware of is the side effects of dopamine when you're giving it. So there is the dopamine mnemonic, so you can get like dyskinesias and things, nausea and vomiting, obviously off symptoms, psychiatric symptoms, and the list kind of goes on. But the key thing is that what you want to try and avoid in all patients is on and off phenomena. So people with L-DOPA will typically remain responsive for kind of 3-5 years, but they will eventually lose their responsiveness. And that is why we don't start it straight away, because it's our best treatment and we don't want them to lose effectiveness whilst the symptoms are quite mild. Now you will see, you will be asked, can I have a treatment holiday for my L-DOPA? The answer is no, because you have an increased risk going forward of neuroleptic malignant syndrome and actual paradoxical worsening of the L-DOPA and less responsiveness. Now, if we compare this to some of the others that have been mentioned, all the others really are relating to dopamine agonists, except for entacapone, which is obviously a catecholamine methyltransferase inhibitor. So all they're trying to do with the entacapone is once again stop the breakdown of kind of dopamine. So you have increased kind of duration of action. But as we know, these really aren't as good. And actually, if you compare these with dopamine agonists, then levodopa is better for motor symptoms. It's better for improving activities of daily living. It does have fewer adverse events, but it does have more motor complications. So that's key. The dopamine agonists are less efficacious across the board. And particularly, they're much more linked, as you probably have read, with sleepiness, hallucinations, and impulse control disorders, which is why you must discuss this with these patients. And remember, with hallucinations in Parkinson's, if you start noticing this on, for instance, levodopa or dopamine agonists, the first thing to do is reduce the dose. And then we want to be careful about adding in antipsychotics because of their mode of action with regards to blocking dopamine. But you would want to use low-dose quetiapine or clozapine in those instances. So out of these, L-DOPA would certainly be the first choice, and you would titrate slowly. And as I said, you would want to ensure that that patients achieve good levels, and this can be given in a myriad of ways, apart from oral, NG, but also as constant infusion. So you will get some patients who have gut infusions of L-DOPA to prevent on and off period. All right, so let's move on to question 4. Okay, so we've got another 30 seconds left. Have a think, and then after that, you can type your answers in and we'll take. Okay, so let's leave it around there. So there seems to be wide varied kind of responses. Okay, and let's have a look at what the answer is. So yes, levodopa A is the right answer. Now, the thing is with this, it's not a simple question. I can understand why people have gone for different things. Parkinson's is a clinical diagnosis, and there was a lot of kind of disagreement. I find, you know, as a medical student or a foundation doctor, what other scans do I need to do? Surely you can't just start someone on a pill. Now, there are some utility of some of the scans that you may have, that you can see here. So let's go for the simple one that we can exclude straight away. Lumbar puncture does not have a role. In the very rare instance, there is Japanese encephalitis, which can cause Parkinsonian symptoms. That's just that will impress your seniors, but that's not something you're going to do. So lumbar puncture has no utility. Now, if we look at start apomorphine, so can anyone type in, does anyone know what apomorphine is? Or has anyone heard of it? Just yes or no, has anyone heard of that as a thing? Heard of it. Good, Ryan. Thank you. You've been very vocal. I like that. So yeah, apomorphine, that is something that we use. It's a dopamine 1, dopamine 2 agonist, and it's very short acting. You can't give it as a pill because its bioavailability is shocking. It's like 2%. So you give it IM or subcut, and it's used for patients who have sudden or unpredictable on-off periods, which is a side effect of, for instance, the levodopa and the dopamine agonists that we talked about. So, you know, it is very good, and it can be used in some of the non-motor symptoms as well, but it's not going to be useful here, all right? It won't control the actual problems. Now, MRI head. Can anyone think of a reason why I would want to do an MRI head for a patient who's presenting with Parkinson's or Parkinsonian symptoms? Rule out other causes. If it was very sudden onset, rule out dementia. I like it. Exactly. So you do the MRI head exactly to rule out other conditions. So obviously this is the to differentiate, is this Parkinson's versus Parkinsonian Parkinsonism. And obviously, if we are thinking Parkinsonism, there's a whole list of things that we need to think about. So as you've mentioned, obviously we would think of things such as possibly tumors that are affecting the areas, vascular Parkinsonism, so I'm looking for any changes there that could have caused this. But the whole point of doing the MRI head is also to look for atypical signs of Parkinson's disease. So particularly your Parkinson plus syndromes, because they will have quite unique changes in terms of the MRI findings. So for instance, if you look at multi-systems atrophy, one of the common things that you will see in the cerebellum is something called the hot cross bun sign. And I like that because I like hot cross buns. So this is a particular type of brain damage that you get in the cerebellum. And that's why with people with MSA, you will get a phenotype of cerebellar disease, which is why we ask, why it's asked that you do a cerebellar screen. Likewise, if you do the MRI and you see changes, particularly within the caudate area, then you can get something called hummingbird sign, which is seen with progressive supranuclear palsy. And another one that we've talked about is normal pressure hydrocephalus, which will cause identical problems with mobilizing and things like that. So once again, that can be very, very useful in MRI. And one other instance where this is important, apart from excluding other diseases or where it doesn't quite fit with typical Parkinson's, is if there's been no response to levodopa after around kind of 12 weeks. So if after 3 months of treatment, there's no response to their motor symptoms, you would want to do an MRI. Likewise, if they're extremely young onset, now you may have heard of pesticides being linked with Parkinson's, but once again, if I was seeing somebody who's got Parkinsonian features in the young, I'm thinking of things like Huntington straight away to send and Wilson's disease, in which case an MRI is very, very important because of wanting to differentiate that. Now, Emma's asked me, sorry, I named people, briefly explain the difference between Parkinsonism and Parkinson plus. So we will touch on this, but Parkinson's disease is that triad. So it's problems where we have with the substantia nigra of changes within the kind of basal ganglia and in that apparatus where we have relative dopamine deficiency existing as that triad. Parkinsonism is a collection of symptoms seen within Parkinson's, but where the damage is not necessarily there. So it's not where you have the substantia nigra being and the changes there. So it's a constellation of symptoms. So for instance, the typical patient you may see on the ward has just isolated increased tone. They don't have the tremor. They don't have necessarily braided kinesia, but they do have a bit of rigidity. And so you would say, for instance, okay, actually this is a sign of Parkinsonism. So they have some of the symptoms associated, but they may also have additional symptoms that you would not expect within typical Parkinson's. Parkinson plus syndrome refers to patients who present like Parkinson's, albeit with some slight nuances. So they have plus features. So they have, for instance, we'll talk about it, but early onset Parkinson's, they may very well have autonomic features quite early on, additional features with cranial nerves being involved. And, these are the ones where we say that they're Parkinson's plus. And these are the ones where the MRI head can be very, very important. And typical features actually that you can see is that, for instance, some patients with Parkinson plus versus Parkinson's, if you have Parkinson's, you normally have one side of the body which has the tremor and which has much more increased tone. With Parkinson plus, for instance, in subtypes such as MSA, you can see it's bilateral increased tone. You can have bilateral tremor. So you have strange features which will make you go for that. Now, the DAT scan is something else. So you will see this. Now, this has no utility in any guidelines for the diagnosis of Parkinson's disease. As we said, this is a clinical disease. But for people with Parkinson's plus syndromes or thought to be kind of drug-induced, for instance, the DAT scan can help you differentiate between Parkinson's and Parkinsonism. So there is some use, but it's not there to diagnose Parkinson's. And for somebody like this in this question, who has got clear symptoms of Parkinson's with affecting daily life, you would want to give them a levodopa trial, and you should expect to see a marked improvement in their functionality. So you can read about kind of Parkinson's disease severity index scores and things. You usually see a marked improvement in their ability to complete tasks. Okay, and that's why, as I said, we don't give it straight away until it's affecting the quality of life, because we know that it only has kind of a 5-year window while it works in patients, and then they start to have kind of the off effect thing. Okay, let's, there's another slide on this. So the Parkinson's disease therapy, so MDT, it doesn't matter if you're in the OSCEs or PACEs or whatever, mention the MDT and everything. These patients need a lot of workup. Obviously, they need the physios, they need the SALT team, they will need all sorts to help them with their disease. As we mentioned, maybe their sleep insomnia, all these kind of things. So levodopa is first. Dopamine agonists, as we've said, they're not brilliant. They are sometimes trialed in patients who are younger than the age of 50, just to put that out there. Just because they, in that population, they can sometimes be proven to have slightly more efficacy. However, you know, I wouldn't routinely do that. Antimuscarinic agents is because of the siluria. So many these patients will have extreme saliva production, so we give that. MAO inhibitors such as selegiline, they work very, very well. Once again, these are monoamine oxidase inhibitors, particularly type B, and these will once again help with stopping the breakdown of dopamine and allowing actually for increased synthesis. And then we've already talked about subcutaneous apomorphine, which should be used for sudden on-off periods. So patients who are suddenly off, and I can tell you it's quite frightening seeing a patient with an off period. They will look pretty much peri-arrest, peri-mortem. And so you need to be able to kind of attend to that. And the big thing you want to differentiate in those patients, I should add, is things such as neuroleptic malignant syndrome that will present with, you know, sweating, increased tone, clonus, all these kind of features. So that's something to be aware of. And then obviously you may have heard of deep brain stimulation. And this is where we stereotactically kind of implant a kind of electrode and basically almost like a little pulse generator. And what that does is it increases stimulation of your subthalamic nucleus and your globus pallidus to basically, instead of basically by producing regular stimulation of this area, we lead to more kind of synchronous movements and muscle kind of contractions rather than the haphazard kind of manner that we see it in patients who don't have DBS. And what we know is that once you have somebody with DBS, they actually, not only does it improve their quality of life, but it decreases actually the levodopa dose that they need to try and help with their symptoms. So that's just something to be aware of. Let's go on to question 5 and go about a minute and 30. Please could you wait until it's over to write your answers down, not to ruin it for others or to misguide them. Okay, Birat, I've told you, yeah, wait until it's over to submit your answers because you don't want to sway people. Okay, so you've got about 10 seconds left. And we'll stop there. Right, so most people there have gone for B. We've had a few with E, and that's quite correct. Metoclopramide is the right answer. Now, if this person comes to you, he's feeling sick, he's vomited, and somebody's given him something to try and to help with it. So straight away, you're looking for a antiemetic that's been given. If it wasn't there and it wasn't that he'd been given antiemetic and he's just nausea, sick and vomiting things, this could be to do with his levodopa. It's something very, very important. And the fact that if he's getting worse, looks more unsteady on his feet, is he having an off period? Okay, so these are things I think of. And remember, Parkinson's disease patients who are septic, by the way, can present actually looking as if they're on an off period, but they won't present. They will present with worsening kind of, or should I say, increased tone and worsening of their symptoms. Now, ondansetron, obviously, as we know, that blocks kind of serotonin receptors, and they are found everywhere, really, not only in your chemoreceptor triggersome. And actually, just so that you know, there are actually ongoing trials with ondansetron in Parkinson's disease. So there is the TOPHAT trial, TOPHAT trial, which is actually looking at ondansetron in reducing hallucination burden in Parkinson's disease patients. So ondansetron is quite safe. Now, if we look at the other options, IV saline, you're not really going to do much wrong with IV saline, but that's not it. Gaviscon, no. And risperidone here, I mean, it's about reading the question. So risperidone you can use, again, in patients with psychotic features as part of their Parkinson's. It's all about using the lowest possible dose and being very careful to titrate. And obviously it's about reading the question, because he was given something for his nausea. So metoclopramide is the correct answer. And this is something that all of you, as you kind of move on and become F1s and things, be very careful when you prescribe metoclopramide. Blocks kind of D1, D2 receptors. It can cause profound neurological problems, not only in Parkinson's, but also you may hear with your youngsters, particularly females, who will have ocular gyrate crisis and basically Parkinsonism features. And in those patients, then you need to give them antimuscarinics to try and deal with that. But yes, metoclopramide should not be given for very often, certainly not in a Parkinson's patient. It doesn't matter how well controlled they are. Can you describe, Bharat has written, can you describe it again? Describe what? If you want to type, and then I can describe. What are you looking for? Are there any other questions about that? Basically, be careful when you're prescribing. Ondansetron, the only thing you really need to know is that it causes constipation, so don't really want to give it to people who are already constipated, and increased QT. With ondansetron, so you want to be careful. Any other drugs to avoid in PD patients? Ooh, there's a list. Oh, that's a list. There's lots of drugs to avoid, more so for interactions with their more so with their interactions with the medications. I'll come back to that at the end because there's quite a few. Certainly metoclopramide, antipsychotics, these are kind of the main things you want to kind of avoid, but yeah, we'll come back to that. So let's move on to the next question. Oh, well, no, sorry, I don't know these slides very well. So whatever, drug-induced movement disorders, right? Okay, we're talking about this. So yes, akathisia. So actually this is important. So a lot of patients with Parkinson's disease, as I said, will have tremor, but a large proportion won't. But they will complain of inner restlessness, all right? And that's something important to remember. And that would be, you would still count that as a kind of positive feature or something supportive, as I said, of Parkinson's. It's not a kind of gold standard diagnostic. It's once again the Braided Kinesia. As I said with the tremor, these are common causes of tremor. The one thing I'll mention about is the lithium. So lithium, obviously, you should expect to find tremor. The moment that it goes coarse and the tremor is coarse in nature, you know the patient is outside of their drug levels. Normally, you expect the drug levels to be kind of 0.5 to 1. As soon as they get the coarse tremor, I don't even need to take a blood level. I know that it's probably over 1.5 and that they're on too much or they're under excreting because of some renal problem. Acute dystonia, as we've mentioned, classically for metoclopramide, and the key one there is, as I said, ocular gyrate crisis, because of how it works. So they will have rolling up of the eyes, and it'll be kind of in it's a dystonic reaction, so it will revert down and keep going back up, and obviously that is quite distressing. Now, neuroleptic malignant syndrome is, as I've mentioned, a very important thing about using antipsychotics in patients, and this is a very severe disorder which is characterized by hypothermia, rigidity, and the key thing with the rigidity is that it's not lead pipe; it is completely I've only met one with an NMS, and you can't even bend the leg. It was so obvious. And with this, they will have associated increases in their creatine kinase, which can go into the 30, 40,000s, because of the hypermetabolic state that they're in with this level of muscle contracture. And with these patients, these are the ones that you would strongly think about early on, giving dantrolene to try and actually reduce this and treat this, as well as discontinuation of the antipsychotic. And they will become hypothermic, and that's only because it's not septic, but it's because of the increased muscle contraction and catabolism that is taking place there. Obviously, other key things to remember is, as I said, Parkinsonism from prolonged antipsychotic use, so you do want to check that quite carefully. And tardive dyskinesia is not only from antipsychotics, but even from levodopa, as we know. So it's something that obviously you have to counsel patients that they will have, for instance, the commonest thing, which is lip smackering and things like that. And this is, as I said, as you start to wane from your responsiveness to levodopa, that this occurs. All right. So let's move on to the. Oh, didn't see that. So I'll give you 30 seconds and we'll see which one. All right, let's leave it there. Some people want to put some good one. One person has thought E, B, okay, we've got a few E's and B's. Okay. Okay, so the right answer here is progressive supranuclear palsy. So let's just talk about this quickly. So, so the key things here is that obviously, as we said all the way through, they're complaining of problems in keeping with Parkinson's or Parkinsonism. But it's mentioned here that there is some subtle eye movement disorder restriction of upgaze, and there's disinhibition. Okay. Now, with people with Parkinson plus syndromes, you usually get much earlier kind of cerebral involvement, in so much that they are much more likely to have personality change and other features like that. And this supple eye movement is important to remember. This isn't just for upgaze, this can also be for downgaze, and this is characteristic of supranuclear palsy. Okay, and this is why I was saying that if you see somebody like this, doing an MRI head, like was in the other question, would be useful, because that's where you would see particular findings such as the hummingbird sign. And actually, if you search it, it does actually look like one. Now, if we look at the other options, it mentions that he's obviously come to this clinic quite early on. He denies a lot of autonomic symptoms, but there is a history of fall, and he is on some doxazocin as well. So this doesn't really fit with idiopathic Parkinson's disease. We wouldn't expect him to have falls early on in his diagnosis, and he does show some other symptoms which are a little bit strange. Now, some of you may ask, well, could this be dementia in Parkinson's? Well, and what's the difference between that and Lewy body dementia? So if you have cognitive and if you have motor symptoms and cognitive symptoms within 1 year of those, then that is Lewy body dementia. All right. If it's been over 1 year after the motor symptoms that you start getting actual cognitive issues, that is dementia secondary to Parkinson's disease. So from this, when we look through these, the only real options that it can be, there's nothing to suggest there's any drugs involved. So the big thing is this multi-systems atrophy or progressive supranuclear palsy? Now, people with multiple systems atrophy present in two different ways. So you either have MSAP, which is particularly Parkinson's features. They have florid Parkinson's features, but which can be atypical, so slightly bilateral increased tone, or for instance, much more likely to have absent tremor, for instance. But these patients will have less of the autonomic features. They still have some possible hypertension, but they may not have the bladder and bowel disturbances suggested. You then have the second phenotype, which is your kind of Scheidreger's, which is your cerebellar features. So they have massive incoordination. They will have issues with nystagmus, problems with kind of fine dexterity movement. And this is usually bilateral. So that's one thing. And then in progressive supranuclear palsy, we do expect to see autonomic features, but they're usually a little milder, all right? And that's important. So with this, if you guys read anything with this, a suggestion of problems with eye movements in this context, you should think progressive supranuclear palsy. Obviously, you wouldn't be wrong to put a differential of MSA, but the key thing here is to understand that he has plus features apart from signs of Parkinsonism, and therefore idiopathic Parkinson's disease is not a top differential. Okay, let's move on to the next question. I'll give you about a minute. Okay, so does anybody want to pass it? Okay, I'm seeing BBE, seeing a few things. Okay, so the right answer here is dementia with Lewy bodies. So what we can see here is that obviously there's been concern about how this person's been doing, but actually, yeah, what we can see is that quite early on that they've got memory issues. And we can also see the fact that there are some features concerning with the multiple faults, which could be a lack of insight in things. However, we can't ignore that there are some Parkinsonism features once again. Now, as I said, if there is cognitive impairment within less than a year of the motor features, this is indicative of dementia with Lewy bodies, okay, versus Parkinson's disease associated dementia. Now, with Alzheimer's, I wouldn't expect those features with the kind of extrapyramidal side effects. Normally, they won't have any neurology present in the initial stages, certainly, and that's why we use things such as the Addenbrooke scale to try and work out, obviously, the cognitive decline, as well as mockers to map this going forward. Vascular dementia, with this as well, we would expect with vascular dementia, vascular Parkinson's, there's usually bilateral features. He doesn't describe the usual kind of gait that's described. So remember that French word, French term I used, they will often have that very small steps, upright posture instead of bent over. And actually their falls risk is actually lower, so they don't seem to fall. So overall, this does seem to fit that. And with Parkinson's plus, she's now moving outside of that age group where I would be thinking, As I said, these normally present 70s, depending on the subtype, 50s to 70s, and we'll go through that later. Okay, so let's move on to question 8. Let's give this about a minute or so. Okay, give you another 20, 30 seconds. Okay, let's leave it there. So here obviously is one of those conundrums. You found somebody with cogwheel rigidity, he's got a tremorless hand, he's got slow shuffling gait, I've got the diagnosis. What's most consistent? Now you may recall we were talking about some of the unusual features that will occur in people with Parkinson's plus syndromes. But actually, as we said before, Parkinson's is a clinical diagnosis. So the best way to show that this is that you trial L-DOPA. So actually, while you can have asymmetrical tremor, B is indeed the correct answer. You would expect for somebody with Parkinson's to have rapid improvements in their motor symptoms on starting levodopa. If you do not see a response, and this is why I mentioned once again a lack of response to levodopa, despite good doses being taken, so we would say kind of at least kind of 600 milligrams, that these patients, if they're not having a response at 12 weeks, should have an MRI ahead for further investigations, because it would suggest that they probably have a Parkinson's plus syndrome. Now, I'm not denying that, as I said, asymmetrical tremor, well, we expect that with Parkinson's disease. Asymmetrical tremor is what we expect. Patients can have bilateral, but it'll always be one side that's worse. Likewise, the cogwheel rigidity is worse on one side than the other. Now, late falls, this is exactly what I would expect in Parkinson's disease versus a Parkinson's plus syndrome, where early falls or early signs of autonomic system involvement will be present. Gradual progression, well, all of them will gradually progress. And preserved cognitive function, that doesn't mean anything. Whilst cognitive function can be affected in plus and idiopathic, you have patients with, with idiopathic Parkinson's in their 40s, although rare, it does happen. So that's not the best way. The most consistent is the lack of response. Now, somebody's asked about, for me, just to talk about the cognitive symptoms. So yes, it's exactly what you've written. If you've got Lewy Bodies dementia, I would expect within less than a year of you complaining of motor symptoms compatible with Parkinsonism, that you have cerebral cognitive symptoms, okay? Whereas if somebody was Parkinson's with dementia, I'd expect them to have had their motor symptoms for more than a year before there was any cognitive deficit. I hope that makes sense, Emma. If it doesn't, I will explain again. So yes, lack of response is certainly the best one. And let's just talk a little bit about these. So we've given an overview. So progressive supranuclear palsy, Parkinsonism, vertical gaze palsy. Importantly, as I said, it can be upwards or downwards. And what we're looking for here is on the MRI, I've mentioned some of the signs, but is atrophy of the midbrain structures. So that's what you're looking for there. And this can be fatal within 5 to 10 years, this condition. So the Parkinson plus are more severe and altered in their presentations. And one of the things I will mention with these patients is a good question to ask is if they say, doctor, I fall often because of this. Typically with PSP and these other plus syndromes, they fall backwards, not forwards or just down. They fall backwards, so retropulsion. Now, multiple systems atrophy, we've obviously talked about, and the key thing here is early autonomic clinical features. So postural hypertension, incontinence, impotence. These are the things I'm looking for. You know, and as I said, bradycardia as well, you do see. And this is where, you know, this is something that we see in patients. It is quite common. I mean, the prevalence is about 5 in 100,000 for those who are interested. But this is where the MRI can be very, very useful. And in these patients, trials of things to improve blood pressure can be very, very helpful as well. So you might have heard of fludrocortisone, but also things such as midrogine, or something called droxidopa. So DROXIDOPA, droxidopa, which is a synthetic amino acid that basically is converted to norepinephrine, which basically boosts the blood pressure. So that's something to think about. Now, cortical basal degeneration is something that we haven't touched upon here, but one of the key things with this is early signs of you can get very early signs of dementia or changes within cognition. It doesn't need to necessarily be dementia, but changes to cognition. And one of the brilliant things is you can get something called alien limb phenomena. And that is very, very cool, where they basically don't think the limb is theirs and it can act quite independent of them. And the key thing with this as well is that the changes in terms of the Parkinsonism features can be restricted to one limb. So they may just have a right upper limb cogwheel rigidity, nowhere else, nothing else defined. And then Lewy body dementia, and as we said, Parkinsonism and the rest, and hallucinations. One of the key things I would say to differentiate hallucination causes, while the content of hallucinations are often thought to be medically irrelevant, in Lewy body dementia, the hallucinations are often quite innocent and nice. So commonly, patients will say that they see people dancing or children singing and things like that. So they're usually happy things, rather than if you think of DTs from alcohol withdrawal, where fomites and hallucinations of bugs and things like that seems to predominate. So it can be useful to know that. Let's move on to, I think it's the last question. And then I'll answer any questions at the end. I'll give it about a minute for this. Give another 30 seconds because we're getting a wide range here. Oh, Ryan switched to could it be B? Right, 10 more seconds. Okay, let's see. So the right answer is indeed, well done, Ryan, for changing your mind. It is Hemi Bellismus. So you may have heard what Hemi Bellismus is. This is, you will, actually, I suggest you search it. For movement disorders, watch YouTube about it. Hemi Bellismus is usually explosive movements, large amplitude movements on one side of the body, suggesting usually basal ganglia injury. Right now, in terms of when we look at some of the other causes here, so if we just look 3-hour history of new coriform movements, and he has a history of type 2 diabetes, hypertension. So people with Huntington's, I can't blame them. It's coriform movements, chorea, we think that. Now, obviously, there shouldn't be an explosive 3-hour history. All right, it shouldn't be just happening within hours. It should be happening months to years. Okay, and we would expect to see the other features, as I've mentioned, Parkinsonian features as well. And Huntington's disease, we expect to see a family history, although there may not be, because as we know of genetic anticipation that is common there. So I wouldn't expect this to present just acutely. Cerebellar stroke, well, cerebellar strokes will cause, as we know, the symptoms of a cerebellar disorder, but it shouldn't cause coriform movements, because for coriform movements, it has to be a basal ganglia lesion, and the cerebellum is not part of that, so it's not going to do that. Likewise, multiple sclerosis, that's not going to make much sense. So actually, even if you don't know, the exclusion is that, so it's Hemi Bellismus. Hemi Bellismus, explosive movements of one side, usually because there's a subthalamic nucleus lesion. Now that can be secondary to a stroke, and certainly that is one of the most common things to think about. But actually, one thing that's very pertinent here is the type 2 diabetes. So this is something I really wanted to take away. Somebody who comes in with choreiform movements, sudden movements on one side, fleeting movements, and a diabetic, you must consider of hypoglycemia. And there are lots of theories about how hypoglycemia can result in this kind of phenomena, but it's supposed to be that the increased sugar basically, actually I'll move on to the next slide. The increased sugar may lead to basically decreased cerebral autoregulation, which means that there's decreased brain perfusion, which means that as a result of this, you have increased anaerobic metabolism and decreased then GABA transmission. And because of the decreased GABA transmission, you get this excitatory phase. So actually for these patients, instead of doing lots of expensive things, we actually just need to bring down the sugars in a timely manner. But of course, for these patients, you want to do kind of CT and things. Now, for other patients who come in with like this Hemi Bellismus, then you want to also, and this is my infectious disease hat on, you do want to exclude some infections that can cause this, such as HIV and tuberculosis. Very rare, but these are something that I would like if you're asking for my help. And in terms of when we say Hemi Bellismus versus choreiform, so choreiform is, as it says here, spontaneous movements that are regularly timed, randomly distributed and abrupt. It can almost look like a very weird dance, but it's exactly that, non-purposeful flitting movements. And a good way to confirm whether or not they're real or psychiatric is to ask the patient to close their eyes, because if they persist even when closing their eyes and distracting them, that suggests that this is actual real pathology. So Huntington's we've mentioned, Wilson's is something you must think of as well, young onset, particularly if they've got signs of early onset psychosis, or they've got signs of liver disease or a family history of kind of disease, or if they've got pituitary problems, because obviously Wilson's can present like that and can also present as hemolytic anemias. And then Friedreich's ataxia, but yeah, I'm not expecting you to pick that up. Firstly, because these patients are normally dead by the age of 30, but also that's not what we should be thinking. It's not an abrupt cause like it is in this instance. For those who are interested about this, then you can search with the hypoglycemia. You can search about chorea hypoglycemic basal ganglia syndrome, which is basically this whole thing to really look at. The only things that aren't listed here as causes, and this is something that can come up in exams and it's quite useful to know, rheumatic fever. Yeah, so Sydenham's chorea is a common presentation, or commoner than you think, because obviously rheumatic fever is still extremely common in India and Asia in general. And obviously this is just a strep infection, and we know that this kind of complications of this include obviously pancreatitis and the need for basically mitral valve pathology, leading cause of mitral stenosis. So I'd urge you to kind of read about Jones criteria for that, but also lupus. So lupus can present as chorea. If you see a young person who's got choreiform movements and you're wondering what to do next, check your blood sugar. I would exclude a stroke, particularly because if they've got lupus, they might have antiphospholipid syndrome, precipitating this. Do a family history, check for all neurology, but do an ANA and an anti-double stranded, and that's what I would do. So to finish off, we're just going to talk about Huntington. So as we said, autosomal dominant condition. This is a trinucleotide repeat CAG disorder that will show genetic participation. So as we go further down the family line, this is inherited more, the copies increase, and you get earlier and more severe onset of symptoms. Obviously, don't be fooled by the lack of a family history, because they may have died of other conditions. And obviously, it may have been misdiagnosed. And certainly patients with dementia are misdiagnosed with that. Can anyone write down in the notes of what's the eye sign that you would look for and what's the blood test you would do? If anybody wants to write in. No, I think everyone's done for the day. No, so you would want to, actually, I forgot my own question. What did I ask? Oh, right. So, yeah, you would want to, for these patients, obviously you can measure things such as serum copper levels and things which are diagnostically useless. But you really would like to check the corilloplasmin levels, and obviously the Kaiser-Fleischer rings, which is a very good sign where copper deposition in decimates membrane of the eye. But the key things here, you would want to do MRI, because you'll see typical changes there, with increase in the size of the lateral ventricles and the horns because of striatum loss, but genetic testing. And for chorea movements, you can give tetrabenazine, which is what's used for severe choreiform movements to try and assist that. And that's antimuscarinic. All right, so that is the whole thing.